Well, it's 1 o'clock now, and we want to start this webinar. The webinar is, as you all know, is about the cancer mission, and we're giving an introduction to all you need to know about this mission that is still quite new for us here in Denmark. And my name is Anne Overgaard Jørgensen, and I work as a national contact point and program committee member for the Cluster 1 Health Cluster here in Denmark.
And I'm Emma Winter, and I also work as a national contact point and PC member for the Cluster 1 Health. The webinar will be recorded, and your microphones are muted and your cameras are off. Please ask the question in the Q&A function on the computer, and ask as many questions as you want. There will be time for a question after each speaker, so please ask the question for each speaker right after the presentation, because then they will be free to log off. If you have any technical issues or comment, please use the chat for this. We have an agenda where we will welcome you, Anne and me. Then there will be a session from Annika Novak from the Commission on the Cancer Mission. There will be two researchers cases by Ulrik Lassen and Søren Tollestrup Askegaard. And then there will be some closing remarks by Anne and me. This is just some information for you. If you want to contact us, you can see that we are NTPs, as we mentioned. We are also national contact points for the partnerships under Cluster 1 and the Cancer Mission. And the slides will be shared with you after the webinar, and you can find our contact information here.
Yeah, and I want to say a bit about where we work. We work in the Danish Agency for Higher Education and Science, and we're based in Copenhagen. And our office is named the Eurocenter. And as we told, we work at national contact points, NCPs, for Horizon Europe. And our task is to offer you free counseling and information about opportunities in Horizon Europe, all the 3 pillars. And we can provide you information about requirements for rules for applying and so on. And we can provide you with news from Horizon Europe. Moreover, we are also program committee members, so we're representing Denmark in program committees under Horizon Europe, where we have dialogue with the Commission about the content of future work programs, and we also have dialogue with the other member states in the EU. And we have a list of our services here. We do counseling via email or phone. You can always contact us by email or phone. And we also offer client meetings if you have a bigger case that demands we meet face to face. And then we organize webinars like this one, and information meetings, network meetings, courses, and so on. We have a magazine called EU Indblik in Danish, which we publish twice a year. It's on paper. Then we have a lot of social media activity where we inform about the Horizon Europe. I want to give you a very brief introduction to Horizon Europe. There are 3 pillars, and as you can see, the second pillar, we have an arrow pointing to the most important program, which is the health program in Cluster 1. And the total budget for the Cluster 1 is 8.2 million euros. And the cancer mission is part of this cluster. Horizon Europe is the 9th framework program for research and innovation by EU, and it has a quite large budget. The largest ever is nearly 85 billion euros for funding in research, innovation, and social translation, and it lasted 7 years from 2021 to 2027. And the solution and the sort of aim is to offer European investments in order to shape our future. As a new feature in this framework program, the missions were created. We have 5 missions in different areas. Today we're only going to talk about the cancer mission.
Will you get the presentation, Annika?
Yes, hello, good afternoon. Just a final test. I hope you hear me well.
Yes, it's very nice, thank you.
Lovely. Okay, then I can immediately start while trying to share my screen. My name is Annika Novak. I'm the head of sector, leading the team working on the cancer mission, on the implementation of the cancer mission. So just give me a quick confirmation whether you see the slides. Can you see it?
Yeah.
Yes, we see it.
Sorry.
Very good. Okay, let's start. With the first, at least it's not moving on my side. I will start again. So you should see now a very dense populated slide. Is that correct?
Yes, that's correct.
Okay, so I won't go through all the details of that, but this is the full summary of the cancer mission. So without going into the challenges, to give some background, I mean, the cancer mission, it is a new instrument under the Horizon Europe program. It is aimed as giving a different tool to do research, and it is a portfolio of actions. So it should go across the disciplines and is intended to achieve a bold, inspirational and measurable goal. And that goal for the cancer mission is to improve the lives of more than 3 million people by 2030. So the timeline of 2030 is applicable to all 5 missions. And for the cancer mission, that should be achieved through prevention, cure, and for those affected by cancer, including the families, to live longer and better. And this quite ambitious goal is to be jointly achieved with the Europe-Speeding Cancer Plan. So the Europe-Speeding Cancer Plan is a policy document, a communication which had been adopted by the European Commission more than 2 years ago, so in 2021. So it's a parallel policy initiative, but it has to be seen together with the cancer mission. So both initiatives, the cancer mission being more on the research and innovation side, the cancer plan more on the policy side of things, but they are combined, they are developed in the design in parallel, so that also then now the implementation goes hand in hand between the services in the dialogue with the member states and also with the stakeholders. I will come to that in a moment. So there are concrete actions outlined or covered by the mission on cancer, which then also partly incorporated into the cancer plan. So there is a kind of overlap if you put these two initiatives next to each other. But the policy-related actions which the cancer mission has launched has been then also included under the cancer plan. So therefore, mission objectives, so stretching from the area of understanding to quality of life, with quite a focus now on quality of life issues. There are transversal priorities, which are then taken into account when designing topics, when implementing one of the concrete actions, which are in the area of to address equity, innovation, childhood cancer, and personalized medicine. For the first 3 years, we had a total budget of 365 million, which we have already, as you may know, planned or in 3 work programs, so from 21 to 23. As I said, and that will now come in the next slide, it is closely linked, first of all, with the Europe-Speeding Cancer Plan. So the close linkages translate into that the mission supports the implementation of the cancer plan by also creating a quite dynamic link between I&I and policy. And that's exactly what the missions, I mean, all of them should be about, that it's not stays in isolation in the R&I, but also looking at in which respect and wherever possible policies can be helped shaped by generating new knowledge and evidence, but also to be a point of contact with European citizens, as citizen engagement is one of the characteristics of the missions. So I will also come to that in a moment. So that's where we see the synergies or the close linkages. But in order to deliver on these close synergies, we have, together with our colleagues in DG Santé, so the Director General for Health and Food Safety, who are responsible for the implementation of the cancer plan, that we create what we call joint governments at EU level. So in any conversation with the member states experts, we convene what we call a subgroup on cancer under the public health expert group. So it's an expert group which is composed of health and research ministries. They send both the delegates, and any aspect of implementation, be it for the Commission, be it for the cancer plan, we bring that to the attention of this group to get also then the advice, the feedback from member states, but from both angles of health and research. The same we do for the dialogue with the with the stakeholders. There we have what we call a stakeholder contact group under the health policy platform. So that's a digital platform which hosts many stakeholder groups, and there we do regular webinars also to inform about the work we do, about the projects launched, about the policy activities, to get also the feedback, obviously, from the stakeholders. Internally, so among the Commission services, we have a joint implementation group. So this combines many different services that have policies that are related to cancer, be it in the area of environment, of data aspects, of agricultural policies, and so on. Moving on, still and staying in the area of governments, which is a quite complex issue, to be honest, and we're always trying to simplify, but it's not that easy. Even that slide shows you there are different layers, but I will concentrate what we call now the National Cancer Mission Hubs. So we have, as I've just explained, an EU government, or governments at EU level, to make sure that we coordinate at EU level. But the same we would like to see at the national or regional level. And that's why under the Work Programme 22, we had a coordination and support action that will support the creation of National Cancer Mission Hubs. To put it simply, it is to have a permanent, similar structure in each of the member states and associated countries that will then support the implementation at that level. Some member states have already created what they call mirror groups. So that brings together the different stakeholders at national and or regional level, depending on the national setting. And these mirror groups are now becoming part of will be most likely developed to mission hubs. And other member states just starting from scratch to build these groups. So in this CSA now, all member states are represented, including Denmark. For the others, I mean, mission NCPs have been created specifically to provide information on the missions work program. And there's also a parallel project, the CSA on TRAMI, which started more than 1 year ago, which looks more at the horizontal aspects of implementing the 5 missions. Moving on and just finishing on the government's part. So these national cancer mission hubs, it is the ECOS project behind. It's led by the Portuguese Institute. And it should really help aligning the different programs also at national and regional level, and also the national cancer plans or cancer strategies which exist in member states. It should bring together the stakeholders and citizens and initiate a regular engagement and foster policy dialogues on cancer prevention and control. It should facilitate the cooperation of research on health ministries, but also then in the long term provide really a network of collaboration among these hubs, so that member states can learn from each other, exchange best practices, which will then help to implement all the actions at EU level. So now turning to the work programs. As I said, we have had a budget available of 365 million for the first 3 years. Why that? That goes back to the Horizon Europe regulation, where the missions have been included. But the budget per se was fixed only for the first 3 years. Missions are now undergoing a first review and assessment process. So looking what have been achieved, what are the challenges. So very soon you will, or we will as a Commission adopt a communication and report back, so to say, to Parliament and Council, but obviously to all stakeholders, to demonstrate what are the missions really about, what has been achieved in the first 2 years. And that should invite member states and also members of the Parliament to discuss the missions, and also then kind of decide of the budget that missions can go ahead, that they are a useful tool. We hope that this assessment will be endorsed, so that we then can go ahead with the budget as of 24. So far, this is an overview of the calls topics we have included so far. So 21, 22 programs obviously have already been evaluated and projects have started. 23 is now being evaluated in June, so that we then can enlarge the portfolio of projects in the 4 objectives. So the house, this is something which the Cancer Mission Board has initially proposed, which should illustrate how the mission has been built. Moving on, I would like to quickly also highlight what we call the flagship initiatives. So first of all, the AnkinEU, that's a research data platform which is being developed, which should help improve the understanding of cancer. So this is already launched through a CSA in 21, which should deliver us a blueprint on how such a platform should be built. So something we expect to receive after the summer. In the area of prevention, a cancer prevention center has been proposed, which should provide evidence on cancer prevention. There we are in discussions with the Joint Research Center, which has already quite an extensive information pool on cancer in their knowledge center on cancer. In the area of diagnostic and treatment, we will join the efforts of launched under the Cancer Plan to build comprehensive cancer infrastructures. So there, from the mission side, we will aim to strengthen the research capacities of existing or future comprehensive cancer infrastructures. And for that, coordination and support action has just started in May, CCI4EU, to develop training programs. Finally, in the area of improving quality of life, a cancer patient digital center has been proposed, and also for that, we have commissioned a study which should deliver us very soon a concept how such a center could be built. Then I have summarized the beneficiaries coming from Denmark. So under the work program 21, this is what I have found. So the AnkinEU, that's for the data platform, the CSA, which will end already in autumn this year. The first topic is in the area of quality of life, and the second in the area of screening, so the DIOP-RADAR. 22, I have also summarized, or this is what I found in the proposals, so the participation in the mission calls, to give you an overview on the participation from Danish partners. At the very bottom, you see that's the ECHOS, that's for the national mission hubs, where the Ministry of Health had recently joined the consortium, or will join. Moving on, I think briefly also, synergies go beyond the Europe's Beating Cancer Plan. So this is the most important initiative, but there are many other initiatives and programs at EU level that are important, that will help to achieve the mission's goals, but also where the mission can play a major role to help implement. So we have initiatives, as I just said, the Knowledge Center on Cancer, under the remit of the Joint Research Center here in the Commission. In December, Council recommendations on cancer screening were adopted by the Council, by the ministries or member states. And also to highlight the recently adopted communication by the Commission, giving a comprehensive approach to mental health, where cancer is also mentioned. Same goes for also legislation, the European Health Data Space, which will give a legal framework for the exchange of data, primary and secondary use of data. So this is obviously an important legislation which is now currently under discussions by the Council and the Parliament, within which then the digital initiatives of the Cancer Mission will fit in. We have built, I will come to that in more detail in the next slide, we are seeking to build synergies also within the Horizon Europe program. So mainly, so far we have managed that to do with the partnerships under the health cluster, like the Innovation Health initiative. But we are also looking and trying to co-create with the European Innovation Council or the Research and Training Program. Similarly, very closely linked is our efforts to the EU for Health programs. All the kind of topics launched from the health side are built in complementarity with our topics and vice versa. The Digital Europe supports our digital initiatives, and also just to mention as an example, the Recovery and Resilience Facility that has been a special temporary fund given to member states to address the challenges after the pandemic. But there, some member states have used these investments to invest into cancer-related infrastructures, for example. The next slide shows you more concretely where we have, since the launch of the mission, achieved that dedicated topics were identified or jointly built, for example, with the EIC and also the Health Initiative. From the EU for Health program is just one example of many. So under this program, considerable budget has been already earmarked and implemented. There were also at the very beginning of the mission 2 topics under the health cluster, while the mission itself is financed mainly through the health cluster. But it's not all about the work programs and policy activities. We have what we call a Cancer Mission Board. So this is a set of 15 experts that help us, give us advice how to implement the missions. And these board members are also very active in reaching out as ambassadors in member states. So they participate in national events, they promote the mission, they interact also with the ministries to discuss aspects of the mission, and does help us really to reach out in member states. We also have some citizens engagement activities ongoing. So we started with some smaller focus group in some member states to explore the views of citizens in the area of health promotion, prevention, and screening. And recently, beginning of this year, we have started an engagement with young cancer survivors, parents, and also careers through workshops to discuss their needs, to see what could be the solutions in terms of R&I or policy approaches, which is a really interesting and useful exchange. We had workshops beginning of the year, which informed and helped organize the conference then in February. And recently we had a follow-up event with the same group of young cancer survivors in May. So this is something, an engagement, which is really new, which is, I mean, for the Commission, really innovative. And that will be continued in the next months and years. And that's also an engagement or something which would like to see from the member state side, that they engage more directly with citizens. With that, I would like to finish my presentation. I will share these slides, obviously, so that you also find the links I have here. If you really want to go into more details, what is the mission about, the synergies, what is the whole background? So I advise you to read the implementation plan that has been published. So it gives you quite a detailed operational course of how we now implement the mission. We had also leaflets, which I advise you to use. They are translated. They give you short description, what is the mission about and some of the activities. But you also find short videos on the conference. There are always the videos from the info day, so giving detailed information on the calls so that we're out. So that gives you even better picture of what has been achieved so far. And with that, I thank you for your attention.
Thank you very much, Annika. At the moment, there are no questions in the Q&A function, but I think they will be there in a minute, maybe. If you can stop share your slides. Yes, wonderful.
Well, I can start with a question for you, Annika. Could you say a bit about the next work program? When can you next time apply for money via the EU Cancer Mission?
Yes, we have slowly started the discussions with the member states. Just had one meeting so far. So it has just started. I can't share any details, I'm afraid. And as I said during the presentation, there's also this review and assessment process, which will lead to the adoption of a communication. Again, a summary of what has been achieved so far in the 5 missions. And that should seek then the endorsement by the political level that we can continue, and continue means then also that we have the budget we need to implement the missions. So this communication is due for July. We then should have the discussions with Parliament and Council in autumn. And in parallel, we are preparing a work program, but the final decision on the budget will only come later. So we expect to be able to adopt beginning of next year.
Okay. So you expected that the work program will open in the beginning of the new year, and then the calls will open?
Yes, but New Year is long, so I can't say if it's first quarter.
Second. Of the timing, yeah, small sense.
Yes.
Yes. I don't believe there are any questions. You will share your slides with us afterwards, and we will send it to the attendees.
Yes.
Wonderful. I think maybe we should go for the next point on the agenda. Ulrik Lassen, you're up with your presentation, if you're ready. We're a little bit before schedule.
Perfect.
Yes.
Wonderful.
Can you share your screen?
Yes.
Mm-hmm.
Can you see my screen?
Yes, perfectly.
Okay.
Wonderful. Thank you.
So my name is Ulrik Lassen. I'm head of the Department of Oncology in Copenhagen at Rigshospitalet, and also professor in oncology at the University of Copenhagen. And I've been asked to share my experience with EU projects. So right now I'm involved in these 3 projects. Only the middle one, Primrose, is part of the Horizon mission, but they are all quite similar in how it is both with regard to the application process and carry out and evaluation. So the first project, PCM4EU, is under the EU for Health plan, Europe Beating Cancer, with the grant number noted here. The second, Primrose, is in the Horizon mission call, and this is not up and running yet. It will start in after summer. And the third one is also a Horizon project, OncoValue, that has started early this year. The first two, PCM4EU and Primrose, they are very closely connected. So I'll talk a bit about them together. And as I mentioned, PCM4U is EU for Health, and the other one is Mission Caller. And they both deal with what we call drug-like clinical trial. It's a family of independent investigator-initiated pragmatic clinical trials in precision medicine, inspired by the design of the original drug protocol that was published in Nature 4 years ago. The idea is some sort of precision medicine in umbrella or basket trials. An umbrella trial is a trial where you deal with one type of cancer, but you treat differently dependent on different genetic mutations. And in a basket trial, you treat the same kind of mutation in different types of cancer with the same type of drug. So it is a combination of different cancers, different genetic mutations, and different treatments that are being tested. And we're using a portfolio of already registered drugs. And the whole idea of these trials, which are similar to the two first cancer projects, EU cancer projects, is that you open a specific cohort for each tumor type combined with a molecular change that could be a mutation and a specific drug. So if you, for instance, have a drug that is approved in the EU for melanoma based on a specific mutation, then if you have a patient with, for instance, lung cancer with the same mutation, then the agent is only approved for melanoma, but we would like to test if it works in lung cancer with the same mutation. So we open a cohort for lung cancer with this specific mutation, and then we treat with this already registered drug. And in the first stage, we treat 8 patients. And if no patient has benefited, then we close the protocol and publish that this GCP monitor clinical trial was negative. But if some patients benefit, then we increase the number of patients with additional 16 patients. And if we there have more than 5 responses in total, then we consider, is this worthwhile to continue the development? And then if so, we go into stage 3, where we plan to have maybe more than 100 patients to get more evidence to see whether a new indication of this particular drug should be sought for. So in practical, we could have more than 100 different open cohorts with maybe 10 different agents and a lot of different tumor types. So it can be multiple combinations in each cohort. So in the PCM4EU, we want to combine the expertise across borders to promote this kind of trials. And it is coordinated by Hans Gelderboom from Leiden University in the Netherlands. In total, we have 17 participating centers in this project. And you can see it covers both some of the more well-developed countries as Eastern European countries with less financial support for the healthcare system. It was launched in January this year, and it runs for 2 years in total. And the work packages is as described here. The first work package 1 is the coordination. And in work package 2, it's about implementing and distributing information about molecular diagnostics and molecular tumor boards. In work package 3, which I'm chairing, we try to implement this kind of drug-like trials in more countries in Europe. And in work package 4, it's about implementation and dissemination of knowledge. In work package 5, it's about equitable access of the treatment across borders. So it can both be sending patients to a country where this kind of trial is open, or it can be open the trial in more countries. so we can assure that patients throughout the whole Europe will be able to be offered these promising treatments. And Work Package 6 is about training and education. Primrose is very close to this, but it is regarding precision medicine repurposing system using pragmatic clinical trials. And it is coordinated by Kjetil Tasken from Oslo University Hospital. Here we have 24 partner sites involved. So many of the sites are the same that are involved in PCM for EU. So there's some additional ones here. And here you see the work package in this protocol. It's more diverse, it's more complex, and it is to be launched just after summer. And this is ongoing for 5 years. So it's both about design of expansion cohorts and common data management. It's about algorithms for synthetic control arms. It's about expansion cohorts, early access, health economics, social innovation, project management and policy, communication and dissemination, and ethics requirements. And we have several active drug-like trials that are the core of these 2 projects. This figure shows on the top right the ongoing drug-like trials. You can see in the blue second row. The first one is the original drug trial, and then there's Impress, that is the Norwegian trial. Then FinProof is the Finnish. ProTarget is the Danish, Megalith is the Swedish, Must Plus is the French, and then there's a Portuguese that is almost ongoing, and there's a British called Determine. And the idea is that the sites that have ongoing trials, they compare, they combine as a body with countries, partnering sites that don't have these trials yet, so we can share information and help to develop these kinds of protocols. And we try to make sure that they are as alike as possible, so it can facilitate both data sharing and also sharing of patients. And the way we want to also make synthetic data sets to get more data to compare with, to control benefit for, is based on different data sets that are listed here, with a number of patients that have been included in precision medicine treatments in the recent years in the partnering sites. So in general, you can say these drug-like clinical trials is an open innovation system for precision medicine implementation. So we want to spread out this through Europe under these cancer plans. So it's sort of a self-organizing open innovation ecosystem. And there are many potential self-citation goals and aims in this system. First of all, of course, we want to make clinical evidence and get new, better treatments for the patients. We want to be able to document the evidence of these agents and make sure that they will be available for all patients throughout Europe. So we need also to work with our health technology regulators in order to get this up and running. Then the last trial I'll mention is this, which was under the Horizon Health call in 2022. This was approved, and the protocol is called OncoValue, implementing value-based oncology care at European cancer hospitals. So it is an AI-based framework for assessing real-life effectiveness of novel cancer therapies in real life. The aim is to unlock the full potential of real-world data, and we will enable and guide hospitals to collect and harmonize high-quality real-world data, and we'll use it to empower and train health regulators and health technology assessments in order for the decision making. So we try to develop tools for the collection, procession, and evaluation of real-world data. So we try to build standardized data collection throughout different hospitals. At the core is Helsinki and Copenhagen, where we have the EPIC medical record system. So this will be the first use case, and then we will try to implement the tools, AI tools that are being developed also to other medical record systems. And we hope that we can develop governance models and quality frameworks that can be used by the regulatory bodies across Europe in order to get the full value of real-world data. So this shows the project at a glance. Most of all, it's about collecting high-quality comprehensive data in some selected use cases, and we start with breast cancer and lung cancer. And then we will expand the collaboration between leading cancer institutes. So there are different work packages about data collection and future frameworks based on AI tools, and then demonstrate the validity and other European setups. That is the main issue. And here you have a little more details. We will use text mining and natural language processing algorithms and also neural network algorithms. We will use this for imaging data. And a common model for unstructured data is the OMOP model, but there are several other models, and it will be based on federated dashboards. These are the partners in this project, and Helsinki is the coordinator of the trial. So a little about my personal experiences for these both applications and also starting it. So the PCM4U was launched late in 2022 and OncoValue by January 2023. And as I mentioned, Primrose will start after this summer. It all started I was contacted by the coordinators of the 3 different projects and asked to take part, mainly because we had one of the drop-like trials up and running for the first 2 applications. And since we had a master observational trial for precision medicine within the EPIC system in Copenhagen, we were asked also to join and take active to be an active partner in the OncoValue project. So we had frequent virtual meetings and decided how to distribute the tasks of the writing process. It was supported by an office that support this kind of applications. It's called TopStarts. It's from the Netherlands. It was a very hasty project. We had limited deadline. So actually I had limited time for consulting with our regional office. So it was very much handheld in collaboration with the other sites and TopStart. And I learned that it is important to be a comprehensive cancer center, to be a coordinator of this kind of application. So actually we would not have had the possibility of coordinating such an application ourselves, since we have no comprehensive cancer centers according to the OECI accreditation system in Denmark. But I can tell you that we are actually in the application process in Copenhagen, and I also know that in Aarhus they are considering to do so as well. After the grant approval, of course, I had close contact with the local offices for legal and financial aspects, both with the grant agreements and the coordination, and also financial aspects about the applications. So we have help with the oral process, but of course we have our local research office at our department who are responsible for the details about the accountability of the grants in their own department. For all projects, we have had physical startup meetings at different European sites of the coordinators, and we have close and regular meetings within both the steering committees and the individual work packages of all the projects. So being work package leaders of several work packages in 3 different EU projects, it's quite time consuming, but it's a very good network to be in. So what I learned is, yeah, well, it's time consuming, but I also learned that it is important that we get OSI accreditation as a comprehensive cancer center. And I can see next time I will be part of this, I hope that we will have better startup times so we don't have such short deadlines. And I would like to involve the local EU office earlier on during the application process, because I think much would have been easier and less workload for me if I have used their experience before and not after the application process. And I think this was my last slide, and I'm happy to take questions.
Thank you, Ulrik. That was a very nice presentation, and it was very nice both to hear of your project, but also your experiences with the more practical part of the process. One thing I didn't think you covered was was you contacted by a coordinator, or did you contact someone about this EU project? How did you start getting involved?
So I had an invitation from the coordinators. We already had a.
Did they found you?
Well, we already had a collaboration because we had the main 4 sites doing these drop-like trials. We already had a collaboration, and actually it was within this collaboration where we share data that we discussed when they saw the call, should we make an application to expand this throughout Europe? So it was sort of the core, and I was part of the core, but I was the only site of those 4 that was not a comprehensive cancer center. But the other sites were.
Thank you. Can you elaborate a bit on what is the advantages in being in an EU project in relation to being in a national project? What did you gain from it? Besides you talked about this network, is there other aspects of the project that is where you have an advantage in being in an EU project with different nationalities?
Well, I think that if we're just doing our own project, then there are some of the things that we would like to ask that we will not be able to do because we wouldn't have the funding. It will be difficult to get the funding, and it will be with a more limited number of patients, so the evidence would not be as good. So when we join forces, then both we can have better chance of getting funding, and then we have much better data to perform these analysis that we want to do.
Also, could you say a bit more about the application writing process? Was it difficult? I mean, I know you were probably one in charge of coordinating all the different parts of the application, but could you say a bit about how it was to write an EU application?
So we at the meetings, we decided different sections of the application, who should be responsible for this section and so on. And then, so I had a part that I should write, and then other sections that others should write. Then they needed some information, and they sent up some questionnaires where we needed to fill some information. And I also sent something out to some of the others, so I could complete the section that I had to write. But I think in total we had 4 weeks from when we decided to make an application until the deadline.
Oh, that's
that was very
it's a
very
short
tough.
Yeah. Are you thinking about getting involved in another EU project in the future? After you have some experience with it, would it be easier to get involved another time?
I think so, and I think so also I've been invited to be more involved in as a Danish representative in some of these discussions in the EU. So I think I will know a little more in advance about what would be what's going on, and try to, of course, share the information and make sure that that we can sort of plan it in advance and get the idea of yeah, how important it is and what you can get out of it.
Thank you very much, Ulrik. That was a very good presentation. We're very happy that you will tell us a bit about it and the audience.
Do we have any questions from the audience? Because we have
We
plenty
don't
of
have any
time.
questions at the moment.
Okay.
Will you be able to share your slides after the presentation?
Sure.
Wonderful.
I will.
All right.
Thank you
Thank
so
you,
much.
Ulrik. That was very good. I think we will move on to the next case presentation. It's by Søren Askegaard. Sorry.
Næsten rigtigt. Almost. Søren Askegaard is good enough. I don't know why people always need to use my middle name. But,
sorry.
Sorry.
Do you have any slides you will present?
I do have slides.
Perfect.
If you allow me to share my screen.
Yeah, we have made you co-host, so you should be able to
Yeah.
share. Sorry.
Okay, is that working?
Yeah, it's working.
So start my video so that you can see me speak eventually, if possible.
We can see everything.
Perfect.
Okay, thank you for this invitation to come and present our project. I do not have the same experiential background as Ulrik just presented, so this will be a work in progress or a project under formation presentation, but I hope that it can be useful any which way. So my name is Søren Askegaard. I'm a colleague of Anna Schneider-Kamp, who is actually the PI of this part of the EU project. But she could not be here today, so I was invited to sit instead. And of course, I would like first and foremost to present you maybe with a bit of background, because even our colleagues here at the department are asking us, so what are two consumer researchers doing in the cancer project? So I'd like to start by elaborating a little bit on the background for our participation in the Cancer Prevention at Work project that this presentation is about. So SDU, and more particularly the main campus in Odense, is basically a host to a quite significant international hub of researchers and research in what we know as consumer culture theory. That is the research unit that we represent. Is called Consumption, Culture and Commerce. Consumer culture theory as an international research field is basically a cross-disciplinary and social-culturally informed approach to consumer culture, consumption practices, and the economy of symbols in market exchange processes. And what do we mean by that? Well, we mean by that we study the various cultural logics at stake in our contemporary consumer society. We also study the individual and social behaviors and dispositions that are sported in consumer and market contexts. And then we're also interested in the meaning system that is produced by the contemporary market and consumption processes. So we at this unit, we have at least 15 years of research oriented towards health, starting out in an intersection of consumption, bodies and health, mainly in relation to food in the beginning, but developing into also looking at behavior, health and technology, various types of service encounters, etc., etc. We have done this research in close collaboration with initially with Aarhus University, but also later University of Lille, University of Melbourne, and others. And basically the point of departure for our endeavors here is that we realize both through our cultural and social observations and also from our own work, the increased salience of consumer and service encounter logics in healthcare systems. So increasingly, we have built also collaborations with significant institutions within healthcare, both public and private, for example, Odense University Hospital. So the team behind Cancer Prevention at Work in our local context are these two people, my humble self, but first and foremost, Anna Schneider-Kamp, who is an associate professor here and also has an honorary associate professorship at the Center for Digital Transformation of Health at the University of Melbourne in Australia. What we bring to the project is basically on the one hand expertise in qualitative health research, user involvement, patient empowerment, patient pathways, and health technologies. On the one hand, and consumer culture logics in health and healthcare encounters on the other. I'm currently more involved basically in another focus area due to another big grant in climate research together under the auspices of Sebastian Mernil in the SDU climate cluster, but that we're not going to talk so much about today. And the reason that we were approached, I'll come back to that, by our international partners is probably due to this buildup of insights and research in consumer practices in the encounter with healthcare systems. So we have a variety of reporting and also research publications from previous health innovation partnerships, such as the Human Fit and GOT, as I mentioned here. So without this prior expertise, I doubt that we would have had the relation in relation to this project that we have had. I think it's also important for me to point out the connection with cross-disciplinary encounters. Initially, so first and foremost, I think it was mentioned on a previous slide. I'm currently a chair of the Danish Institute of Advanced Studies here at SDU, a chair of social science. And through DIAS, we have had several interesting discussions, cross-disciplinary encounters, research presentations, generation of ideas, as is the point with ESs in general. And this led to a formulation of a set of projects concerning facilitators of and obstacles to participation in cancer screening programs. That we formulated in collaboration with Professor Kåre Christensen, who's a DS Chair of Medical Sciences, and Assistant Professor Maria Timofeeva, who's also a DS Fellow of Medical Sciences. That led to projects on colorectal cancer screening, and one was based on the model of health capital developed by Anna Schneider-Kamp, trying to search for elements in patients' health capital or citizen capital that would facilitate or create obstacles to participation in cancer screening, in colorectal cancer screening. And another project, a twin project in colorectal cancer screening, adherence among relatives facing initiative in the Danish Twin Registry. And so for the COPPA, the Colorectal Cancer Screening Patient Pathways project, we made an application to the Independent Research Fund of Denmark and got very good evaluations, but as many of you, I'm quite sure, has also tried, good evaluations, but a negative outcome. This is a very interesting project. We're not going to give it any money. It did, however, mean, and Ulrik Lassen was also pointing to this, it meant that the project was almost at least ready-made when a request came from the University of Bologna about participation in another project of cancer screening programs that they were initiating, namely the Cancer Prevention at Work program that I will present to you now. So the partners involved in the Cancer Prevention at Work are the following: University of Bologna, the PI and the coordinator is Professor Paolo Bofetta. Then we are involved with the team here from University of Southern Denmark, particularly looking at the social, economic, and cultural assessment of participation in such cancer screening programs. And other partners then are also University of Torino, University of Oviedo, University of Heidelberg, and a number of university hospitals in Germany, Spain, Slovakia, Romania, two places in Romania, as well as a large number of municipal, local, regional, and national occupational public health institutions. Because, as you will see, this is a project that targets cancer prevention screening programs in the context of occupational situations. So basically, here are some of the basics of the project. The chronic infections contribute to a significant proportion of human cancers globally, 13%. Heliobacter pylori, hepatitis C virus, and human papilloma virus account for 75% of these cases, which means that they are 10% of total cancer burden. This, of course, are not my area of expertise, but as stipulated by the research program from the University of Bologna and the partners, the idea is that health promotion initiatives in collaboration with occupational health surveillance enables the reach of broader population. So the proposed research aims to incorporate primary prevention programs for these infections in existing occupational surveillance systems, meaning that the Cancer Prevention at Work will conduct pilot projects in the included countries to assess effectiveness and cost effectiveness of cancer prevention at work, including also the impact beyond directly involved workers, that is, relatives, family, and so on and so forth. CPW will also identify behavioral, socioeconomic, and cultural barriers, facilitators of the implementation of such cancer prevention interventions. And that's, of course, where a group of consumer sociologists like ourselves come into the picture. So here's an overview of the work packages, a couple of packages that are more oriented towards management and dissemination. Then a work package for each of the infectional diseases, work packages 2 to 4. A work package assessing the behavioral and social factors involving the participation or not in the prevention programs. That is then our part and our share of the whole setup, and then work package 6, which is less sociological, more economical cost effectiveness assessment. So we can say that we have 3 distinctly medical work packages, 1 sociological, largely speaking, sociological work package, and 1 largely speaking economical work package involved in the entire framing and setup. So the main tasks for us in this project in Cancer Prevention at Work is then to investigate behavioral and social cultural barriers and facilitators. So we're currently hiring a postdoc to design qualitative studies, a set of qualitative studies, because of course we will need to take into consideration the institutional and cultural contextualizations in each of the involved countries. And we also need to take into consideration that a prevention program that comes through an occupational health surveillance system will have particular benefits, but maybe also some backlashes depending on the general trust in the employer, and the branch and the authorities involved in such a program. And then we will do a follow-up methodological development project where we will design a questionnaire based on Anna Schneider-Kamp's model of health capital that we will try to test in larger scale on the cancer prevention network cohorts. Our model, the health capital model, is basically inspired by Pierre Bourdieu's theory of practice, which can very, very briefly be formulated as capital times capital plus field equals practice, and translated into normal language for non-sociologists. The interrelation of lifestyle and resources mobilized in relation to healthcare leads to what you are inclined to do or what you will do. So that is the sort of, in very, very briefly, the sketch of the theoretical framework that we are building our work on. So here's the model that we are operating with. So you can see that there are three main parts or segments of variables or factors that we need to take into consideration. There is the patient's health capital, which includes economic resources as well as social and cultural resources, but of course also biographical personal antecedents. On the other hand, we need to take into consideration that people's orientation in the healthcare system and people's orientation in relation to their own sort of personal health oriented activities is dependent on a number of other health actors. Obviously, a number of public health actors, but also digital health actors. Most medical staff today know that they are not alone in defining what is the problem and what might be the solution. There are a number of competing expert systems flourishing out there, both online and of course also from commercial actors. And some of that type of knowledge is also brought to the patient's knowledge by a variety of related people in the social networks of relatives, families, and friends, and so on and so forth. Online contacts in various social media fora. And all of this informs the barriers and the facilitators of engaging in cancer prevention programs. And one can just think about sort of the backlash of participation in vaccination programs following various social debates that unfolded in very different ways in various countries following the COVID pandemic, to see the complexities of the formation of these sort of barriers and facilitators of prevention participation. So the primacy of our participation in this project is basically methodological. That means we are going to try to develop and target a version of the health capital model that is particularly fit to the cancer prevention issue, that is particularly fit to the medium that is the employment health surveillance systems, and finally also takes into consideration the national healthcare systems and the national cultural differences of the various citizens involved. On the one hand, and this is of course a qualitative, a main task for the qualitative element of the study or of the project is to try to take into consideration all these different dimensions and screen and also assess the relative importance of each of these differences in order to reach a platform that allows the development of a joint quantitative instrument for measuring the impact of health capital on barriers and facilitators of cancer prevention participation. And finally, of course, development of recommendations for the various involved authorities. So this is basically the same thing all over again. We can skip this. This is just an overview of the different partners that are involved at the different levels. So this is again a more detailed reiteration of what we are going to do. We're going to develop a study protocol and interview guides to facilitate the geographically and culturally dispersed data collection. So executed in close collaboration with all the partners. And we are sort of the methodological and conceptual guiding staff for this collective work. And then once we are at a level where we have locally trained staff in all the partner institutions, we can start the data collection and then overlook the data collection procedure. So this is just the spelling out of the first part of the work package, that is the unfolding of the qualitative study in the Cancer Prevention at Work project. And finally, an overview of the time frame for such a project: 13 months for developing the protocol of the qualitative studies, 18 months for the data collection, 26 months publication of preliminary findings, and so on and so forth until the project is terminated 4 years from now with the final report on the survey study along with recommendation about how to address barriers and facilitators. So yes, some takeaways. Of course, we don't have any results. We cannot share any sort of problems and issues with this complex design involving many partners and many countries. We can come back and share some of those later on. What I am able to share with you is on the other hand, I think the importance of novel grounds, the fact that we have been trying to sort of pave new ways in terms of including social cultural factors in what used to be a predominantly econometric study of consumer behavior, garnished with some psychological choice models. I think that has been important. The importance of cross-disciplinarity and our encounter with our colleagues at DIAS, our medical college colleagues at DIAS, cannot be underestimated. Thirdly, the importance of experienced partners with the EU project system, predominantly at the University of Bologna, is very significant. And then also concluding a little bit along what lesson in the prior presentation, the importance of being ready. I'm not sure that we would have been able to present and produce a work of sufficient quality for inclusion in this set of work packages had we not had a more or less ready project from the collaboration with the DIAS colleagues and the application to the Independent Research Fund of Denmark. So I think these are, at least from my perspective, 4 important issues that I would like to highlight as the takeaway. So thank you for your attention, and I don't know if there are any questions.
I don't believe there are any questions, but we can ask some questions. Can you elaborate a bit on which value it gains for you to be in this sort of project with this angle in another field than you're maybe used to be in?
I think we have learned a lot from sort of having the discussions about the logics that we are talking about on a daily basis that pertain to, let's say, I wouldn't say insignificant, because in a lot of senses, the meaning of life for a lot of modern people comes from their consumption activities. So it's not that these are unimportant, but of course, in some ways, the significance of your leisurely activities or your favorite brands, etc., pale in comparison with questions of life and death. And so I think that it's been an interesting and also, in a certain sense, legitimizing experience to be involved with and to mobilize your knowledge and your models and your insight together with such a serious problem as the cure and the prevention of cancer. So this is not the only project where we are engaged in this. We are also together with another DS colleague, Dr. Christine Stabell-Ben, involved in assessing, citizens' assessment of the governmental vaccine program over the winter, the attempt to promote vaccinations of very young children, aged 2 to 6, against the flu, in order to prevent the spread of flu in the elderly populations and prevent a renewed serious epidemic of flu-related or maybe even COVID mutations, kind of whatever epidemics. So based on our insights into the social logics of beliefs about certain service offerings, we have been able to enrich, I hope, the insights from the medical faculty. But the medical faculty, on the other hand, has been able to inform us about where is the relevance and pertinence of our insight, and where is it applicable in terms of medical research.
Thank you. I don't believe there are any more questions. It was a very good and covering presentation, so I think you covered it all yourself. If you stop sharing your screen.
Yeah, I can do that.
All right. I think we now, before time, have reached the end of this webinar. The presentations will be sent to you as well as the recording of this webinar, so you can rewatch it or whatever.
And if you have any questions about
yes.
the cancer mission, then also, always feel free to write or email or call Emma and I. And as Annika mentioned in the first presentation, we expect there will be a new work program for the cancer mission in the beginning of the new year, where you can apply for funding. And once it's ready, we will, of course, disseminate it and share it with you.
Yes. Please just contact us for any questions you might have after this webinar. All right.
Bye.
Have a nice day.